Hello, everybody. My name is Josh Jacob. Welcome once again to our webcast on behalf of Surrey Total Health. As I said, I'm a consultant orthopedic surgeon specialized in hip and knee arthroplasties, if you've seen some of our previous webcasts. And it's my pleasure to invite Mr. Mohamed Imam, a good friend and colleague of mine, as well as Dave Emsley, who's also a physiotherapist, and he's been on us before, and we hope to use Dave again on one of our webcasts in the not too distant future. Mohamed Imam is a consultant orthopedic surgeon, and he specializes in upper limb surgery, that is the shoulder, elbows, and wrists. He's done fellowships in all over the world, very prestigious universities in the Western Hemisphere, both here in England and abroad. He specializes in shoulder and upper limb trauma surgery, as well as elective surgery. He's done his fellowships in Oxford, in the Royal National Hospital in Birmingham. He's also been overseas to Zurich, and of course, last but not least, to America at the Mayo Clinic and the Stedman clinics. He's also an expert in, as a FIFA medical officer in many of the sporting events. And last but not least, he's published very seminal papers, and you're very welcome to Google them up and see his name attached to many of the peer leading papers. We also have Dave Emsley, who's a physiotherapist, who's got experience both in physiotherapy and also his background in sports science. Dave is at the Physio Body Mechanics as a director, and it's my pleasure to welcome you both. We discussed in our previous webcast on the problems of the shoulder in the elderly population, particularly those who have the vulnerability to be affected by COVID-19 and those who have pre-existing illnesses, particularly also affecting the shoulder and elbows, with a specific concern of rotator cuff problems. Now, if I could pose this question to Mohamed first, and then that'll be followed by Dave. What about the shoulder problems in younger people? Say, for instance, the weekend warriors, those who all of a sudden now want to become healthy, take up little sporting activities, do a bit of exercises, aerobics and other things, and lo and behold, they start developing shoulder problems. They can't reach the top shelf of the kitchen or the bookshelf. What advice would you give in respect to impingement problems?
Thank you, Josh. So one of the most common physical complaints is shoulder pain. And let's think about shoulders. Our shoulders is made up of several joints combined with tendons and muscles that allow a great range of motion in your arm. Because so many different structures make up the shoulder, it's vulnerable to many different problems. The rotator cuff is a very frequent source of pain in the shoulder. So let's think about it more. The cuff is a common source of pain, but actually that can be because of tendonitis, because the rotator cuff tendon holding the ball, which is the head, the ball on the top of our shoulders, the tendons might be irritated or damaged, or the bursa above these tendons might be inflamed and swell with more fluid causing pain, or because of impingement. By impingement, we mean when you raise your arm to shoulder height, the space between the top bone here and the tendons narrows, and the acromion, which is the name of the bone on the roof of our shoulders, can rub against or impinge on the tendon and bursa, causing irritation or pain. This is very common, as you've rightly said, in young athletes or middle-aged people. Those who weekend warriors, we see a lot of weekend warriors who have a lot of time in their hands nowadays, including all of us. So when you start doing overhead activities like cricket, tennis, or any other sort of overhead activities, you're more vulnerable to develop the impingement. Those also who do repetitive lifting or overhead activities can have impingement. How can we diagnose impingement? The symptoms might be mild. You can have mild pain that's present both with activity or at rest, pain radiating from the front of the shoulder to the side of the arm, sudden pain with lifting or reaching movements, pain at overhead activities or any activity at the level of the shoulder. And of course, it is very common, and I've seen it a lot in athletes and overhead sports, as they have this pain more frequently. As this problem progresses, the symptoms increase. So you can have pain at night, loss of strength or motion, difficulty doing activities that place the arm behind the back, such as buttoning or zippering. If the pain comes on suddenly, the shoulder might be severely tender. So thorough examination and different treatment options are there, ranging from non-operative treatment, ranging from non-steroidal anti-inflammatory medication, activity modification, exercises, which I'm sure Dave will tell us more about, and physiotherapy, of course. And when things persist, then we can consider other options in the future, of course, including surgery. Another important aspect here, impingement pain can be secondary to a shoulder problem. And that's why thorough examination is crucial here. And I've seen in my practice over the last few years and in different places I've been to, patients who have impingement and been managed for impingement. However, they have what we call secondary impingement. They have another problem in their shoulder or even in their elbow. And because of the change in the mechanics of their arm movement, they develop secondary impingement. So actually here we should manage the main problem either by physio or surgery or whatever option we have will help to relieve the impingement problem as it is secondary. It's like when you have flu, you have cough. You don't manage the cough, you manage the flu, and then the cough will improve.
Very good, Mohamed. Now, Dave, what sort of cuff strengthening exercises would you advise? People get over-the-counter TheraBands and elastic bands and a bit of resistance, but could you actually be a little more specific and help the population who are suffering from impingement syndrome how to actually prevent further tears, strengthen the rotator cuff, and get back their movements?
Yeah, that's a good question, a good point. I'm going to move forwards now because when people have got a tear, so when people have got impingement, it comes in different forms. It was very eloquently put by Mohamed in the fact that some it's just a small pain when they're reaching high up for something on the top shelf. Other people it's painful all through the night. Every movement becomes sore, around the back, moving out to the side. So again, I'm going to take it to the lowest common denominator. It's going to be a very similar thing to a rotator cuff tear. We need to stimulate the rotator cuff and ask the muscles to be moving in a good position. Ideally, what we do is we do a stimulation exercise, which is an isometric or static contraction of the rotator cuff. I've been through it before. I'll quickly go through it again. Elbow bent at 90 degrees. Unaffected hand grips the affected arm. You're going to be pushing the affected arm towards your tummy, blocking that movement. So you're forcibly turning the arm in, trying to immediately rotate the arm with force, but stopping the movement occurring. 3 seconds, 3, 2, 1. You're going to do the same opposite direction, laterally rotating the arm, moving away from the body, holding with the other hand. 3, 2, 1, and relax. The other thing that's very nice for people who are suffering with an impingement pain is actually weight bearing on the arm, but in a safe position. By putting weight through the arm, as long as it's not causing pain, and that's a very key element here, we want to get the muscles stimulated around the shoulder. So going into a kneeling press-up position, just taking a weight side to side towards the affected side. Naturally, if that's causing pain, it's too acute to do that. Not a great idea. I've said it before, I'll say it again. Anything that causes pain, it's not a question of no pain, no gain. Every time you take the arm into a painful position, it irritates that area a little bit more. It becomes a bit more sensitive. So we need to do movements that stay away from the pain, but still try and stimulate the shoulder as best as possible. Now, a key thing to think about is actually the fact that the shoulder and impingement is directed by the position of the shoulder in many occasions. So how are we using the body? This comes back to the conversation we've had previously. Are you sitting at a computer desk for long periods of time? Do we have tension around the rib cage, around the upper thorax, tension around the neck? Are you holding stress in these areas? Because if these areas aren't mobile and aren't able to work, then it will naturally pull the shoulder blade into a position that is angling downwards and increase the chance you're going to keep bashing that humeral head, the top of the shoulder, into the bone, the acromion above it, the hat of the joint. I like that phrase, Mohamed. The hat of the joint, the ceiling of the joint. So if we're not asking this area of your body to move better, then you can do as many strength exercises as you like, but you may well be bashing your head against a brick wall. So when we're looking at that, regular movements, big shoulder rolls, opening up this area, turns of the upper body, moving the body backwards and forwards as if we're soaring. Again, if it's too irritative, if it's too sore to do these movements, please don't push into pain. Please don't do these movements to stimulate the pain. But we need to get this upper body moving as best as possible, get some mobility into the whole system, because when it is a secondary impingement, we need to make sure that we are looking at root cause analysis. Mohamed's absolutely right. I've given you a basic overview here. Getting a detailed examination is a much better way. If you do have an impingement, you haven't had it looked at, please do speak to GP, surgeon, ourselves at the physiotherapy clinic. Looking at it as a root cause and why it's occurring is the best way of getting over the pain that you're feeling, rather than just doing a straightforward strengthening exercise in a position that may not be mechanically the right position to be working in. It's worth trying gentle exercise to stimulate the rotator cuff, a bit of weight bearing, shifting your weight from side to side, encouraging movement in all directions within your pain limits. But please, if the pain is persisting, do contact someone. It's definitely worth getting it looked at.
Very good. Thank you, Dave. Mohamed, very briefly, if you may, we've covered this question that I'm going to ask in a previous episode on whether the virus actually affects the shoulder joints per se. But if the patient contacts their GP and says, my pain is unbearable, I'm on the waiting list, but I've received a letter from the secretary saying that I'm being deferred because of the pandemic. Now, would it be advisable for the GP to inject the subacromial space with steroids or local anesthetic injections to mitigate the acute flare-up of their symptoms?
That's an excellent question. You know, during the pre-COVID era, we used to do routine corticosteroid steroid injection for impingement, either by us, by Dave, or GPs as well. But however, nowadays we have concerns. There are concerns, as we've mentioned in a previous webinar. Steroids are known to cause a transient reduction in immunity, and as per recent evidence from China, they have shown to increase symptoms of the disease and some biomechanical and radiological severity markers in young patients. And further evidence from a large study carried out in the context of influenza, which is a similar problem, showed reduction in vaccine efficiency in patients treated with steroids for musculoskeletal pain management, possibly due to the immunosuppressive effect of steroids and the absorption of intra-articular steroids into the bloodstream. So governing bodies nowadays are advising against giving steroid injection routinely intra-articularly or in person. Of course, there would be a bespoke approach to every patient, but that's the general consensus. So nowadays we stop undertaking intra-articular steroids for everyone, and as what we do in everything else, we undertake a bespoke risk assessment to everyone before proceeding with such a treatment.
Very good. Thank you, Mohamed. Thank you, David.
Thank you.
Thank you, one and all, for joining us, and we trust you've enjoyed this webcast and has been informative. If you have any questions, clarifications, or inquiries, please feel free to contact us on our website or email us at info@surreytotalhealth.co.uk. Take care and bye-bye.
Thank you. Thank you.